Hello, I'm Jo Beer, Chief Operating Officer for University Hospitals Plymouth. Along with the rest of the country, we're experiencing enormous pressures for our services, and I wanted to take this opportunity to acknowledge the huge amount of work that everyone's doing every day to maintain and deliver services for our population. In responding to these challenges, we've made a number of changes with the help of the care groups and service lines and all staff across the hospital in recent months, and I wanted to take this opportunity to share with you the changes that we've made to adapt to these challenges and the current thinking and plans that we have going forward.
So I think there's been an incredible amount of hard work shown by everybody across the organisation, but I suppose particular thanks from the medicine care group to all the ED staff. I think that action plans were put into place really quickly in relation to the CQC report, and I suppose the most significant change really was the split of the entrances to separate out walk-ins and ambulances. And I think that that has made a positive difference in terms of our performance. So I think for a few weeks after, in terms of just looking at our handover position, we saw a massive improvement.
So obviously the CQC came and visited in March, and they raised some really significant concerns about crowding and about the length of time patients were waiting. So the first thing that we did in response to that was we uncoupled our front door. Previously we'd had a single point of entry system, and we separated that out so that ambulance arrivals were seen separately from the ambulatory arrivals, and that had a really significant effect on waits to be seen.
We've done some teaching with the new staff that are able to triage, so at the moment we have all of the eligible staff trained in triage. There is a plan in place for that, and we are trying to uplift our staffing, and as people come through there'll be a more robust plan for triage training them in the future. What we do need to encourage is that even though we are trying to reduce our triage times and meet that 15-minute RCM standard, please do still triage people in clinical priority order. You should have all seen reminders about how and when to use your PPE that will have been circulated in conjunction with the infection control team. We have increased where PPE is available in our department, so we now have face masks on the entrances, and we should be asking all patients and relatives to change from their standard face covering into a surgical face covering. We've increased the hand sanitizer stations that we have around the department, and we now routinely do the COVID screening at the entrance of ED 24 hours a day. Supplementary to that, we have a link with the infection control team, so that is Kerry Richards. She's one of the infection control matrons, and she's our ED link for all things infection control. She meets with us once a month and we review our audits. So the matrons or the unit managers do a walkthrough daily to check that we're meeting the infection control compliance. So this is looking at things like our sharps bins, our daily cleaning, what the staff are or aren't wearing, our social distancing, and then we review that with Kerry towards the end of the month, and that also gets reported through to Infection Control Board, which we report at once a quarter.
So we've moved the seats around to try and maximise the number of people we can safely get in there. We've put some more seats in the corridor areas to give us a little bit of extra flex. We're also looking at whether we can use the chairs with perspex surrounds, which might enable us to sit more people in the waiting area. Other things we've done are, whilst the rest of the trust has opened up the hospital to visiting, we've really strongly resisted that, trying to keep people to the absolute minimum in those areas.
So the other big change that we made was to our ambulance arrivals. When we decoupled the entrances, we now have a trigger tool in place for when we need to put a halo corridor in, and we have a delayed handover SOP for when we have ambulances waiting in the courtyard. We're much more assured that with these SOPs specialties, and with the staff that have been working in those areas, we have better oversight for our patients and they feel safer because we have a joint responsibility for those patients. So although when they're in the back of the ambulance we would expect the crews to take the clinical lead for them as you would if you was the nurse in resus, actually then patients are both UHP and SWASTI's responsibility, and I think we agree that we have better oversight of that now. So we do prioritise patients out the back of the ambulance corridor onto the halo corridor, and we do prioritise patients off the halo corridor into flick.
Next steps that we want to work on are we need to look at our flick process in majors. Resus is nearly always full currently, and that consequently grinds to a halt. So Claire Basanko is leading on a project to look at the way that we can do that going forward. There's an options appraisal being worked up at the moment, and when we know the results of that we will share and try and implement some change in the least disruptive way possible. Just thank you to my team for your continued hard work. I know it feels absolutely impossible right now, but we are doing everything we can to make things better, and I do want there to be a real emphasis on looking after one another.
I think there's lots of other things in terms of closer working between specialties within the trust as well, which I think is an area that we need to build upon, but it's good to see that those closer working relationships are happening. Our next phases are going to be incremental change in a lot of areas, so I don't think you can put it down to one or two initiatives. I think it is going to have to be, you know, for example, myself working with clinical support services to think about how we have a substantive pharmacist in ED to be able to support. What else can we do in terms of, you know, our therapy roles? What can we also do in terms of working with our wards? You know, we are actually getting more discharges now identified the day before, but also in terms of like working with the discharge lounge. So, you know, there's lots of things that just need to kind of keep going and keep going.
In therapies, about 12 months ago, we introduced a new service for stroke patients, and that has reduced the length of stay by, on average, 2 days. In October of last year, we started a 7-day working pilot in physiotherapy. That was based upon the working practice that we put in place over COVID. And that's worked really well and enabled us to see between 150 and 200 additional patients over the weekend. Next steps in therapies, we've secured funding for 15 additional therapists to support the medical wards and HCE. That will improve patient care, it will reduce length of stay, and it will help with patient flow. We've also reintroduced therapy extended scope practitioners in ED. In imaging, about 12 months ago, we established a consultant-led ultrasound service for SAU at the weekend. That has reduced the number of patients that are waiting for examinations on a Monday morning, reduced the length of stay and improved access to SAU. We've increased the throughput of our inpatient CT scanners, and we've reduced the length of wait. We set ourselves a target of 90% of scans being done within 24 hours, and we're achieving that target. We've also more recently supported ED X-ray by giving them additional imaging care assistance, and that's helped improve the flow of patients from ED to X-ray. Next steps in imaging, to work on improving communication between the imaging department and the wards to improve patient readiness, reduce waiting time and improve flow. We want to recruit sufficient number of staff in order to run all of our scanners from 8 until 8, 7 days a week. And we will support the delivery of same-day requests, scans and reports. In pathology, last year we introduced fast-track flu testing, and we've also introduced early day phlebotomy on the medical wards to facilitate the availability of blood tests. Next steps are we're going to be rolling out point of care testing, both within the hospital assessment unit and ED, and in the community, so that patients who don't need to come to hospital can have their tests in the community, and that GPs can access their results quickly and easily. We're also looking to facilitate early discharge for patients presenting with chest pain in ED. In pharmacy, earlier this year we rolled out electronic prescribing. We've reduced the turnaround times for TTAs in the department, and we've recruited additional pharmacists. Next, we're looking to dispense all medications on the day of request. We are looking to reduce the delays associated with controlled drug TTAs, and we've started the rollout of a programme of utilising patients' own drugs.
Unfortunately, with the unprecedented demand that we've seen over the last weeks and months, performance has dipped again considerably, but I think things would be in an even worse position if we hadn't done what we've done. So overall, it's a really, really positive step.